So the SPLENDOUR trial is an academic trial starting from a hypothesis generating data set which was presented some years ago. This data set consists in a trial which was using denosumab to protect the bone, to avoid or to stay away from skeletal related events in a trial in patients with bone mets. In this big trial, the subgroup of lung cancer patients were extracting benefit from denosumab in terms of bone protection, but they were also getting a better survival. So the hypothesis is beyond the bone, maybe this pathway that you inhibit, which is the NF-kappa B pathway, might have an anti-tumor effect. So the hypothesis is denosumab a potential anti-cancer drug? So we just randomized patients between chemo plus denosumab versus chemo frontline, with the idea that denosumab can be continued as long as tolerated over time. Primary endpoint, survival, very clean and very straight to the point. We unfortunately had to close the trial before the end because of the environment of immunotherapy. The chemo was not anymore the frontline strategy, and there were too many competitive trials ongoing around. But we did recruit more than 500 patients, which is not a small trial. And I was telling yesterday, I don't think that the problem of this trial is that it is underpowered. The problem of this trial is purely negative. You shouldn't try to find a reason why. I mean, the curves are completely superimposed. There's no signal of improvement of outcome, whichever outcome, in patients with or without bone mets with denosumab. So I mean, that's where we are. We still have some biomarker assessment. Maybe the expression of the ligand, the rank ligand or the receptors, the ranked receptor, might describe a population of patients who benefit a little bit or benefit, but it would be a subgroup, right? So our question, should you give denosumab to all your patients? The answer is no, definitely no. Sometimes it happened. It was a negative trial.